Well, thank you very much. Great to be here. And NSDA is a wonderful organization to help everybody here with this disorder. And so I'm really honored to be invited to be here with you. My job is to give you the overview, to just kind of try to put everyone in the room a little bit on the same page in terms of the understanding of this disorder. I'm not going to go deeply into any kind of science. It's more the clinical realm, it's more the observational, because everybody here has a lot of observational tools that you can bring to spasmodic dysphonia, and so that's what I really want to focus on. And just to point out, Laryngopedia at the bottom is an online resource, 1,600 images, 40 videos, a lot of articles, and so forth. And so the dysphonia.org website, and then maybe check this one out in other places. Well, dystonia is the disorder that we're talking about. We always call it spasmodic dysphonia, but it's really a dystonia. And dystonia simply means that dys is a prefix that means abnormal, and tonia, so it's abnormal tone in muscles. So that's the problem. It's an uncommon neurological disorder. It's neurological, not psychological. It involves intermittent or sustained muscle spasms that are involuntary, unpredictable. The disorder has no effect on general health or longevity, especially when it's focal, such as here in the room. And it's chronic and unremitting, but it does sometimes evolve, and it can evolve in your favor. In some cases, it's unusual, but it can evolve to worse, it can evolve to better, it can evolve to different. And it's treated with medication, with therapy, primarily speech therapy in this room, or surgery, and you're going to hear about all of those. Types of dystonia, generalized, meaning the entire body, the tone of all of the muscles of the body is abnormal, primarily early in life onset, generalized dystonia. Then there is a regional or segmental, where a person may have eye, a jaw, a neck, a larynx, maybe a limb even. So they're regional. And then there is focal, meaning one or essentially one body part. So it could be the eye, it could be the larynx, it could be the neck, it could be a hand, and a foot, and so forth, focal. And there is the issue with the tone that we have to figure out is the intensity of the abnormality of tone and the timing of the contraction. Well, spasmodic dysphonia, a kind of formal definition is, it's a focal form of dystonia. Okay? It's a neurological voice disorder, and it involves involuntary spasms of the vocal cords, because the vocal cords are made up of muscle, or they are altered, they are moved around by muscle. And so those involuntary spasms cause interruptions of the voice and or just an abnormal voice quality. There are people who do not have interruptions, they just have an abnormal voice quality. And that's a big bugaboo in the community. There are people who disagree with that, but I am pushing this idea that it's, in some cases, simply an abnormal voice quality. So it can cause the voice to break up or to have a tight, strained, or whispery quality with or without concomitant tremor. So we have spasm and we have tremor. Whoops, wrong way. Now, let's do examples of the difference between the tonic, which is the stable kind of laryngeal dystonia, spasmodic dysphonia, and the unstable or classic. So I want to give you actually the difference between the stable, the sustained abnormal tone, and the episodic, moving. So if we do it with the eye, blepharospasm, you can have people where the eyes are squinting in a fairly stable way. There's not a lot of blinking, but there's mostly a lot of squinting. But you can also have people where there's a lot of blinking going on. So there's the more tonic and the more cervical. You can have someone whose neck is turned in a fairly stable way, like this, or you can have people whose head is turned and also shifting and moving all the time, like this. So the tonic and the intermittent. Limb dysphonia, you can have people where the hand takes a kind of a sustained cramped or abnormal movement, or you can have lots of movements happening at the same time. And laryngeal dystonia, also known as spasmodic dysphonia, does the same. Well, some general characteristics, it can seem psychogenic. It can seem that way. And in fact, up until probably 1960, there was lots of comment in the literature about this being a psychological disorder. It's not. It can be confusingly task-specific. So people say, well, why is it that I talk and it's really so bad, but if I sing very high in my voice, it's fine. It's task specificity. Very high voice is a different task from speaking voice. Sensory tricks. The fellow with torticollis and his head is turning and twisted like this, and you say, move your head to the middle, can you? And he tries, and he just can't do it. His head just keeps doing this. Tap on his forehead. He can move around. He can look to the left. He can look up. He can look down. As long as you keep tapping, and as soon as you stop tapping, over he goes again. Well, it's like that as well with the voice, that there are tasks that we can do, and there are therapy implications, because therapists sometimes, latch onto the task specificity and try to get a purchase on the voice. There's short-term variability of symptoms, which is just distressing to people, because when the voice is good at one moment and bad at another moment, the natural inclination is to say, now, why is that? And I will figure this out, and I will thereby take control of the disorder. But in fact, it's just part of the disorder, variability. Like, why was it bad this morning? Why is it good this afternoon? It's very annoying. And then there's long-term evolution. It can become more or less severe. There can be added muscles and the addition of tremor. Sometimes you have people who've had dystonia for a very long time, and they begin to add some tremor after a while. Well, as for cause, the main point I like to make here is that spasmodic dysphonia is not psychological. And why is it that we know it's not psychological? Well, a few reasons. First of all, there is a phenomenology. You put a voice behind the screen, you put a person behind a screen, and let someone like me evaluate the voice. So I don't know if it's male or female, I don't know young or old, but I'm just asking through the screen, I'm saying, could you do this, could you do that, could you do the other thing? I can identify there are phenomena that are very common with spasmodic dysphonia that will lead me to that diagnosis. That phenomenon for non-organic voice disorders is entirely different. So you put a person behind screen A and behind screen B, and one has SD and the other has a psychogenic or functional disorder, very easy to figure out which is which through phenomenology of the voice. Another reason, psychotherapy and psychoactive drugs don't really work routinely. Now, there are people who love clonazepam, and I remember one seminar years ago when a person raised their hand at the end and said, I have been asking around, nobody here, or not very many here, are on clonazepam, and I don't understand that because it's just wonderful, it just works so well. And somebody else erupted on the other side of the room and said, oh, I've tried clonazepam, and all it did was make me sleep. And so you see, there's that problem of an individual who gets a great result of a thing, but not routinely do drugs work very well. And then in my sort of non-scientific way, I have really come to see that people with SD are a random population with respect to psychological issues. They get depressed, they have various issues, but it's the same as my patients with larynx cancer or with vocal nodules or whatever. It is not a different group. Now, how is it diagnosed? Well, you'll find some variation in professional opinion. So I'm just telling you my point is used here, so don't try to apply this to other people. But in my view, it's diagnosed with three things. One is the history, the patient's story. What does the patient tell you? They will give you a voice experience if you ask really clear questions. That is very typical. Second is the elicited vocal phenomenology, having the voice do a lot of different things, sustained high voice, low voice, yell, sing, that kind of thing. And then the laryngeal examination, and those three things will give you an ironclad diagnosis in about 98% of cases. There's the rare patient who needs to go work a little bit with the speech pathologist, a voice qualified one, and kind of help, break the tie. That is very common to have that happen. Well, the typical history is unremitting once established. The symptom complex that patients describe, they'll say my voice catches, or they'll say it wavers, or it strains, or it glitches, or whatever. There's variability with stress, alcohol effects, benzodiazepines sometimes. They hate the telephone. I mean, if you give 100 points to all the various ways that you can make the diagnosis, you give about 6 points to that thing alone. Because people who have vocal nodules or have a vocal cord paralysis will, but many other voice diagnoses, they don't say that they almost come to life and say, oh, I hate the telephone. That's very, very strong for SP. And then difficult sounds and tasks. People will say the numbers, or if I have to give someone my phone number. Many people say, if I'm introducing myself and I have to say my name, it's so hard to say my name. And so those kinds of things happen. And then it's easier to sing, laugh than to talk, or a cry of pain, or a shout of anger. It's like, wow, that came out so well. That's very common as well. Now, I always put exceptions occur because I have, out of about 1,500 patients I've seen in my career with SD, I have a few, maybe 4 or 5, who say, oh no, the telephone isn't best. Give me a telephone and I'm fine. Well, that's a dramatic exception to the rule, but that's the way SD is. You make any rule and I'll find you someone who breaks it. But these are quite good commonalities. Now, phenomenology, I just want to explain and mimic some of the phenomena, because this is where, if you have a really good set of ears, and it's not just acuity, because I don't have the best acuity, but it's sound awareness. It's an ability to think into a sound, to hear a sound and kind of mine it for information. See, in voice disorders, voice phenomenology is a powerful source of diagnostic information. The voice itself, it's not just the patient's history and memories, but it's the voice. What does the voice do? It's three things. What does the voice do that it shouldn't do? What can't it do that it should be able to do? And so it's capabilities. What can it do? Limitations. What can't it do? And 3 is what does it do that it shouldn't do, that I can't mimic, or that, so it's capabilities, limitations, and aberrations. So phonatory arrest, I'll give you AD. A phonatory arrest is when the voice just does its kind of thing, where it sort of stops on you. And you can have a very hard stop like that, where it just catches, or it can be sort of a stop that comes at the end of a string, where it catches, but only after a sort of string. Squeeze down is just where the voice squeezes, but it doesn't absolutely stop. So you can't call it a phonatory arrest. Long ago, people found that it was easier to travel on water than on land. That's a squeeze down, but it's not a phonatory arrest. And then you have strain, so you can have just a sense of tightness in the voice like that. And I'm not really squeezing down exactly, and I'm not catching or stopping, but my voice is just sort of strained all the time. It's what I call non-dysphonic kind of strain. Then you can have, on the AB side, you can have intermittent or continuous whisper. There is the case where the person just has kind of a voice like that, and they're working very hard to keep that much because there's a tonic abductory spasm happening there, or you can have them talking like this, and it's just constantly to whisper, just completely awake to whisper. Now, they may or may not have tremor, and you hear tremor best in sustained phonation. So you can have the tremor is a very regular thing with a singer's vibrato, that kind of sound, but it becomes more insistent and more intrusive. You hear how regular it is. There's not a squeeze down in that. There's not a stoppage. There's not a drop away. It's just wavering. And you can have a tremor that is essential, an essential voice tremor without spasm. So someone might sound like, people found that it was easier to travel on water than on land. Now, you don't hear any squeeze downs, and you don't hear any stoppages, and you just hear that my voice is shaking all the time, and when I sustain, it's going to be like that. So that's just essential voice tremor. That is not laryngeal dystonia. But on the other hand, you can have people who have that tremor, but they also have spasms. So it's long ago, people found that it was easier to travel on water than on land. They needed a clear path. You hear how I'm wavering, but I'm also catching. You hear the difference. So that one might be. So you hear how it's squeezing and grabbing and interrupting this very regular kind of tremor. And then if the dysphonia is respiratory, then you will hear breathing noises. So you could hear them breathing in. This is maybe 5% of people with laryngeal dystonia who have respiratory effects. Spasmodic dysphonia or laryngeal dystonia primarily affects the vocal function of the larynx, but there's a very small number of people where it affects the respiratory function of the larynx. So those people will involuntarily hold their breath, so you'll hear this, they breathe in fine, and then they kind of segment the air. The air flows out in segments, like a so they'll say, I can't blow the air out, I can breathe in. Others say it's the opposite, I can blow out fine, but I can't breathe in. It's like I'm doing a so you'll hear that sort of segmentation of breathing. Now, task specificity, there's some other phenomenologies. We've got squeeze downs, we've got phonatory arrest, we've got dropouts to whisper, and we've got tremor. But some other phenomenology that actually has therapy implications, task specificity, singing voice, not affected as much, very common but not universal. I told you about every rule is broken. I have a few people who have absolutely perfect speaking voices. They don't have any issue at all, not a sign of anything in their speaking voice, but they get above the prima passaggio in the falsetto, and the voice just goes haywire. They can sing in chest voice, happy birthday to you, but they go into falsetto, and it's happy birthday to you, and so it's pure singing task. That's task specificity. So there are people who can put on a big accent, a British accent, and the voice is dramatically less affected. Or they can do sing songs. Long ago, people found that it was easier to travel on water than on. That's what I call reading to children. Registration, cognitive loading. If you have someone sing a song, there's not much cognitive loading because the words are on the page, the music is in the head, and so you're not having to think. But the more you're adding high-level thought to your speaking, the more the symptoms that's a very common phenomenon, cognitive loading. Sensory tricks, somebody's got SD, they jam their thumb up under their chin, and it makes a big change. I had a judge once who sat on the bench, he lifted one foot off the ground, and he could speak much better, he had abductor, he could speak much better, so he said, if I put my hands behind my head up on the bench, I could speak much better. Those are all sensory tricks. that seem sort of psychological, but they're not at all. I just want to point out all of the many muscles that you see here in this left picture. So those are the muscles with laryngeal dystonia, the tone in those muscles. 7 paired and 1 unpaired muscle, and so it's a lot of muscles that can be messed with by the laryngeal dystonia. And I just want to show you, this is normal phonation here on the left, and then we have normal phonation here. That's what the larynx should look like when we're producing voice. That's what mine looks like approximately right now. And then this is normal open for breathing. But now ignore the lower right. But instead of this, an adductory spasm, when you hear a voice do that kind of thing, it's doing that kind of thing, just clamping down. When you hear an abductory spasm, I'm talking along and suddenly my voice goes to a whisper. It's because the vocals are jerked apart and just air comes through. Now there are adductory variants. The normal is here. Actually, I'll play you a little bit of that. And I'm just showing the vibratory blur there. So there's normal. Do you see how stable and steady that is, even though I'm producing voice? And then let's do a sort of tonic. Where is my pointer? Tonic, we'll do here. You see how everything's squeezed in, and you hear the tightness of the sound, I guess, but there it is. All right, let's try that again. So now you hear the voice is tight and squeezed in. All right, and then a tonic fry. See how it's quivering and shaking a little bit, and so that makes the voice just kind of gravelly sounding. And then the classic, where you see the arrests. So that's what's the kind of thing that's happening. Now, respiratory, I think I did that. Can't fill, can empty. Now, laryngeal findings are typically normal. They're anatomically normal exam, but you'll see little tiny quivering movements. Sometimes that's all you see, or you'll see major spasms. And why does it matter? Well, let me just give you some examples. Why is it that we should understand the phenomenology? Examples: tonic variant adductory spasmodic dysphonia. A person comes in and says, long ago people found that it was easier to travel on water than on land. Unless we understand that this can be SD, you're going to run that voice through a lot of different tasks. But unless we understand that that's actual SD, that person gets sent endlessly to speech therapy for a diagnosis called muscle tension dysphonia, but that's not what they have. They have tonic variant adductory SD. Yet, I've seen a number like that. You start them on Botox and they do wonderfully well, you see. So it matters that we kind of understand the phenomenology. A mixed AD-AB, if you're a patient, to give you an example, I had a patient one time who came in, and every time I would see him, he sounded like this. So his voice was mostly like this, but he had an occasional kind of grab in addition. So he had both the abductory, but almost everything I heard was this kind of dropping away. So my object is to say, well, I think you need AD. But in talking to him and mimicking the difference and helping him to hear the difference between those two spasms, he said the following. He said, well, but it isn't the dropping away to whisper that bothers me, it's the grabbing. And that tends to happen more towards the end of the day after I've talked a lot. So we treated him. You see how important it is to understand the phenomenology, because you're going to do the wrong treatment. You're going to treat tonic variant as a functional disorder when it's actually neurogenic. You're going to treat a mixed AD that seems to the clinician more like the AD is the problem, you see. And then another anecdote, I saw someone actually this week who came in having been to a couple of places, good places, but was told you don't have spasmodic dysphonia because she has what I call stage whisper variant. So there are people who have a very tight voice, it's kind of like that, but it's kind of whispering. And I've seen that person diagnosed as abductory SD. That's not abductory SD. That's a very tight, strained voice, but it sounds kind of whispery. You see that? But you hear the strain and the squeezing. So in her case, she was kind of tonic variant, adductor. She'd had it for 6 years, unremitting, speech therapy, nothing worked, Botox is her solution. So you see why the problem is why it's so important to be precise about what it is, what the manifestations are, what the very clear diagnosis leads to very precise treatment. And so you all can be a part of the clear diagnosis by saying, here's what happens, and have your clinician help you through the phenomenology so that we know what it is we're trying to abolish with our treatment. Well, that's just to set the stage for other folks who are going to talk about behavioral and surgical and so forth, but I appreciate your attention. Thank you.